Good morning, everyone, and welcome to this parallel session. My name is Catherine Moyes, and I'm going to be chairing this session today, centred on job planning and service redesign in speech and language therapy. I'll be joined by three speakers today, Caroline, Gemma and Natalie, who I'll introduce in full a little later in the session today. We also will have a pre-recorded presentation from Charlotte Colesby, who unfortunately can't be with us today, but we're delighted that we're able to still share her work as part of the session. So before we kick off with the presentations, I'd like to tell you a little bit about this session and how to get involved. So first of all, this is an impact and innovation session. These sessions are new for 2025 and they're designed to shine a light on some of the key resources, tools and approaches that members across the profession have found to be useful locally and that they wanted to use this platform to share with you. So you'll see a number of these types of sessions dotted across the conference programme for the conference over the next couple of days, and all the sessions are centred around themes that are especially kind of topical across the profession at the moment. So in this particular session, let me tell you what we're going to be doing. We're going to be exploring some innovative approaches on the topics of job planning and redesign. And as part of this, we're going to be sharing some practical strategies. We're going to be hearing some expert insights, and I'll be also rounding off with some key resources for you to give you some ideas to take away and maybe even consider implementing in your service locally. So a final few things from me before I hand over to our first speaker. If you have any questions today, we'd be delighted to hear them. Please use the questions tab on the platform to submit your questions. We'll be answering questions at the end of each presentation, and any questions that we don't get around to answering live today, we'll either respond to via the platform or we'll put into an FAQ document at the end. Just to let you know that we've also got a chat tab, so you can interact with other delegates as part of this session using the chat. Just to let you know, though, that the speakers won't have access to the chat live today, so do make sure you use the Q&A tab for any questions. As you probably know, we're recording this session, just so you're aware of that, and please remember to give feedback at the end. Finally, at the very end of this session, there will also be a code displayed on the screen, and you'll have a code to enter into the Challenge Hub area of the platform. So look out for that as it comes up at the end. So without further ado then, I'm delighted to hand over to our very first speaker as part of this session. I'm pleased to introduce you to Natalie Madden, who's neonatal speech and language therapist from Coventry and Warwickshire Partnership NHS Trust and East Midlands Neonatal Operational Delivery Network. Natalie, over to you.
Thanks, Catherine. So I'm really happy to be here today just to share with you all a piece of work that's been developed by a working group that I've been part of, a working group of neonatal therapists looking at how we can help those working in neonatal care identify their priority needs when working across their neonatal units. So if you can have the next slide, please, Pam. Thank you. So the purpose of this identification tool is, like I say, it's to provide that guidance for how neonatal speech and language therapists work, not only on the units, but as part of that wider neonatal team as well. As a working group of lead neonatal therapists across the UK, we felt that it was really important for us to review the evidence base. And we know that the potential long-term outcomes of preterm and complex infants that spend time in our neonatal units have really potentially poorer outcomes and long-term outcomes, and we wanted to really focus on how we can enhance our services to provide the best outcomes for them. So we devised this tool, and we broadly utilised the model of universal targeted and specialist care, but also not only focusing on feeding needs and swallowing needs, but also speech, language and communication needs. So like I say, I'm sure everybody's familiar with this model, and the model has already been viewed holistically by the wider AHP team members of the neonatal services. And we tend to look at how we sort of support our babies and families on the unit. Specialist levels of care focus on really individualised care plans for those babies and families, and that tends to be our more complex infants. And then targeted pathways of care really help with those interventions to underpin those broader aspects of neonatal care and really focus on whole services on the units that can target wider populations of babies and families that are having that input. And then universal is those embedded principles of care for any baby or family who accesses that unit. And that tends to be working definitely alongside the wider team and embedding those wider principles such as family integrated care, developmental care, neuroprotective care, and baby friendly initiatives. So as we know, for any babies that are receiving neonatal care, there's definitely a number of clinical reasons why they might present with communication and or feeding difficulties. It tends to be that neonatal therapists, because we've had some funding input lately, there are more and more neonatal therapists, but we still aren't necessarily meeting those staffing recommendations for our units. So it's really challenging to then identify who are our priorities and how we can utilise our time on the unit more effectively. So the whole purpose of this was to help those therapists working on the units to identify those babies and families, but really look at that wider aspects of holistic care as well. And like I say, to be underpinned by those fundamental cares of developmental care, family integrated care, and trauma-informed care principles. So this is how we've then branched that out. So we've utilised that specialist targeted and universal model to then provide a one-page profile. So the whole model that is accessible on our Royal College platform now goes into greater depth for all of this. But what I've done here is just given an example of the one-page profile. And this just shows broader examples really of what intervention can be carried out at each level. So and then what we do is later on, we then branch that out even further to really support therapists on that unit to look at how we can utilise that time as well. It just really helps the wider team as well to understand the broad range of care and input that speech and language therapists can have as that wider neonatal team as well. And some examples there are, for, at a targeted level, that could be ward rounds, so supporting with feeding ward rounds or developmental care ward rounds. Specialist input would be those individualised one-to-one focused clinical assessments. And then universal could be how we're supporting quality improvement projects on the units as well. If we go on to the next slide, it shows it broken down further. So the tool goes into greater depth to enable therapists to really see what we actually mean by each of those levels and give them even greater examples. So these are just to show you the broader outline, but when we break down that specialist, we talk about who do we mean that we target for that specialist input, what we mean, when we might do that, and also how. And then for that targeted level, we really look at those babies who are at risk of feeding and speech language communication difficulties, in contrast to the specialist babies and families are those that would have traditionally been those that would have been identified by unit staff and referred to us, but we wouldn't necessarily have always had those targeted and universal babies and families identified. And again, due to the level of funding that a therapist may have or time that they may have on the unit, it really might limit where they can pinpoint their input. And what we wanted to do was move away from only being focused in one area, and to enable therapists to have a greater depth and to utilise their time and think, okay, what is the priority for this unit and for this and for the time that I've got for that unit. And that could mean that they focus on a universal piece of work, which will benefit a wider, broad range of babies and families, rather than seeing one individual specialist case. But it could be for that some units that their priority is to really focus on that specialist pathway as well. But it just really helps them to look and see where they can utilise their time across their working week. Next slide, please. Thank you. So in addition to the specialist targeted and universal pockets of care, we've also introduced a service delivery guide within this neonatal identification tool. And this aspect of it is really to home in and help therapists and their managers and the neonatal team to look at where they have funding on the unit, what that can be used for, but also to evaluate that service, to prioritise and to then job plan. there's resources within there to help them, once they've identified their core activities, then can identify their unmet need, which is crucial for supporting future business cases as well. So for example, in terms of options appraisals, therapists might be able to really showcase, this is how much time I've got for the unit, these are the priorities for the unit, but this is my huge area of unmet need, and if I had an increased time on the unit, these are all the areas of service that I could improve on. It's really crucial that this document is localised to individual services for those reasons, because we really need to account for those levels of funding. And so the document is to work alongside the neonatal staffing recommendations, which have also been endorsed by the Royal College and are available on the neonatal platform as well. They work hand in hand to help staff and teams identify how much time they should be funded for their unit based on these recommendations, and then compare that with how much time they actually have. And then the neonatal identification tool then helps to showcase where that unmet need is. Thank you. So I've just included the examples of where we've broken this down further in this slide and the next two slides of what we've had really positive feedback for from therapists on the ground, where they've been able to really look at how much time they have, what they can achieve across their working week. So these are just broad examples again, and we've started this, and the plan is to review it on an ongoing basis. And it's roughly, like you can see there, it's identified into a service who meets 100% of their Royal College staffing recommendations, down to services that are above 50% staffed, less than 50% staffed, and then services that are not funded for any clinical input, but offer that either as an ad hoc or a goodwill. So you can see the real contrast there if we take this specialist pathway as an example. From the point of view of triaging that neonatal caseload, if you're 100% staffed, you've got a much higher capacity to triage that caseload daily and really identify the critical cases for that day, or where the other embedded areas of need are. Versus if you're an ad hoc in-reach service, then you will only be able to go and respond to cases on a needs-met basis that are identified by the unit. And then if you take it down to discharge planning, for example, the ability to attend discharge planning meetings for those babies and families will really vary depending on the amount of time you are staffed for. Thank you. So if we go to the targeted, so here's some examples of targeted. So again, targeted, there could be a multidisciplinary or a developmental care ward round where you go around and see all of the babies and families on the unit and offer that really holistic AHP as a whole AHP team with lead nurses or consultants from the unit. If you are staffed to 100% level, you would be able to do that on a minimum of once a week basis. It may be able that it's possible to take case more than once a week, so you really are able to capture every family and baby on that unit. Versus if you're less than 50% staffed, then attendance at those ward rounds might be quite ad hoc or will be based on the priorities for that day. And then you will need to capture your unmet need. So it may be that you only are able to access 2 or 3 families on the unit that day for a developmental care round, where there could have been 20 families and babies that actually needed you to see them that day. So that the 18 babies and families would then become your unmet need for that. Thank you. And then on universal, which is, I think the beauty of this slide in particular really shows that the breadth of services that we can offer at a universal level within neonatal care. And broadly, these are provided down into, like we say, those best practice models of care, which of the family integrated care and developmental care, trauma informed and neurodevelopmental that I mentioned at the start, down to areas of clinical governance, staff education and training, and quality improvement projects. And your ability to really partake in these crucial pieces of work, if you are less than 50% staffed or an ad hoc in-reach service, is obviously greatly reduced in comparison to if you've got a much higher level of staffing recommendations. So like I say, these tables really help to really support that unmet need and support a business case for staff teams who are working, who haven't got their recommended staffing allocation, where they can easily showcase to the wider neonatal team and to their management team the areas of the gaps in their services and what they are not able to provide based on their levels of staffing. Thank you. We've also, as part of the tool, provided some useful resources and links. So we devised a developmental feeding milestones and supportive strategies. And this is really useful for those that are coming into neonatal care who are new to neonatal therapy, but also just as a reminder for staff and education purposes as well. So we've got one for feeding milestones and then one for speech, language and communication milestones. And these are broadly divided into gestational ages. So for those babies that were born pre-10 to 28 weeks, up to 28 weeks, and then the gestation of 28 weeks, 30 weeks, 32 weeks, and then 34 weeks and onwards. And it just provides therapists with a range of strategies to really utilise and support their input for those babies and families for what they may prioritise for those areas. And within the tool, we've also got useful links to resources and training courses. So there's a real breadth of information for therapists to be able to access to support their training needs, their development, and developing their services. Thank you. I've broadly talked around this within the previous slides of the universal, targeted and specialist, but I just wanted to quickly give you some examples of that differentiation which we mentioned. So it is really important to individualise this tool to your individual unit. And there's just some examples there. So for example, a developmental ward round could be classed as targeted for some service areas, but other service areas may view that as universal. And that would be very much based on the frequency that they're able to offer those, the amount of their funded time, and also the way that they run that. So for example, a targeted developmental care ward round might be very much where parents are given specific time slots, and they come, and it's very, very parent led, which we really try to embed with all of our ward rounds. But those targeted ward rounds may focus on very specific babies where something's arisen that week, whereas a universal developmental ward round would literally be accessible to any baby and family who is on the unit at that time. So that AHP team may never have met that family before, but they're invited to take part in that developmental ward round to be given the input that benefits every baby and family in that universal advice. We've got an example of a service that might be 30% funded. So if they've only got a small pocket of funding, they might actually prioritise all of that time to fully embed on a quality improvement project, or just to focus on developmental ward rounds that they're aiming to cover a wider range of babies and families, versus you might have a service who has a small amount of pocketed funding that chooses to utilise that purely to focus on that specialist pathway and to only respond to those really core identified specialist babies. And that will be led by the priorities of that unit, the wider medical and neonatal team, and the therapist that's working on the unit. And there's just some other examples there in terms of how ad hoc services might rotate their time for prioritisation, the utilisation of a speech and language therapy assistant or an AHP assistant role means that they may focus purely on universal services to free up the time of the wider SLT team to focus on the targeted and universal pathways. And also we really need to think about how services change based on how long they've been established. So if you're new to a service or unit, you may need to focus on some areas more than others. Thank you. So like I say, that the tool is currently being rolled out now throughout the whole of the England neonatal operational delivery network leads. It's been endorsed by Royal College, which we're really grateful for. So it's available on our Royal College platform. And the plan is for us to review this within 18 months' time so that we can continually update this and keep up with any changes in neonatal care. Thank you.
Brilliant. Thank you so much, Natalie, for that fantastic talk. There was a lot in there for everyone, I think, not just those members who are working in neonatal care services. So thank you so much for going into depth about that new tool. We've got loads of questions in the chat, so I think we've got time for one. We'll get back to everybody who has put in a question at a later date. But Natalie, we've got a question from Ellie who says, I love the concept of considering your priorities and potentially providing universal and targeted support to reach a wider patient group. Just wondering if you were met with any adversity because of this. Sometimes universal work can't be audited and outcomes aren't easily measured, so it can sometimes be less preferred by management.
No, I mean, obviously, I can talk from on behalf. This is really new, so it's just being launched now. But I utilise it in my clinical role as well as in my ODN network role as well. And I can say that we've been met with absolutely overwhelming praise and positive responses. I think the universe within neonatal care, it may be that we're slightly different in that aspect. That the universal principles of care are real high priorities for our wider neonatal team. And because we've managed to embed the model and this identification tool to support all of those wider themes, we're only being met with positive feedbacks at the moment. I'm sure the challenges will come. I'm not adverse to that, but also I think it's really helpful that we are able to, within our universal models, that tends to capture some of the education packages that we offer to the team members. So we are able to audit and evaluate that and how effective that is.
Oh, that's fantastic. Really good to hear that it's been so well received and a success so far. So that's brilliant. Natalie, thank you again so much
Thank
for
you.
sharing that. That's brilliant. So next up, as part of today's session, we have a recorded presentation from Charlotte Colesby, who's Speech and Language Therapy Services Manager from the Royal Wolverhampton NHS Trust. And as mentioned earlier, unfortunately, Charlotte can't be with us today, but we're really grateful to her for providing a video. And as mentioned, Charlotte has very, very kindly also said that she's happy to take questions. So do please put questions in the Q&A tab if you'd like us to pass anything on to Charlotte, and we can get those across to her at a later date. So I think the video is just being loaded up now. So over to Charlotte.
Hello, I'm Charlotte Colesby. I'm the Speech and Language Therapy Services Manager at the Royal Wolverhampton NHS Trust. Unfortunately, I can't be with you today due to my health at the moment, but I'm really glad that I'm able to present to conference. My presentation is about the speech and language therapy job planning tool that I've developed, and I've developed it in conjunction with a whole number of other speech and language therapists in the NHS. So it's been developed by NHS speech and language therapists for NHS speech and language therapists. Others are very welcome to use it if it's of use to them, but I just want to be clear who it's been developed by and who it's been developed for. Quality is the key driver, and there's plenty more on that in a moment. But I just want to remind people that as individual registered SLTs, we are required to provide quality in what we do. And so an HCPC requirement is to monitor and systematically evaluate the quality of our own practice and maintain an effective quality management and quality assurance process, working towards continual improvement. That isn't only the responsibility of managers, that's the responsibility of individual SLTs. And RCSLT says to it should be autonomous and accountable professionals who need to make informed and reasonable decisions about our own practice. And I believe this tool helps us to do that. The national drivers that led me to look at job planning were the two documents that came out from what is now NHSE in November 2017 and July 2019, which looked at allied health professionals and job planning. Those are still available online if anybody wants to take a look at them. Like all NHS professionals, I'm aware of the national pressures on the NHS, and in conversations with many colleagues, we talk about those national pressures on speech and language therapy. We know that speech and language therapy is recognised as a shortage profession, and that was certainly the case at that time in the NHS People Plan. And we know that from the work of Royal College of Speech and Language Therapists and others, that speech and language therapy is a shortage profession. Like most speech and language therapists, I have many conversations with colleagues in my own department and across the country. And I think it's common for people to express frustration in speech and language therapy about the way that activity is counted. And it's usually just those face-to-face contacts and all the other really essential and important things that we do. It's really difficult to get counted. And Also, we've had trouble as a profession for a long time having a way to quantify service capacity. We've been challenged with lots of different ways of managing this, and for at least the last 20 years that I've been working, skill mix has been mentioned. What about trying skill mix? But while it's useful, it's not a magic bullet. And I do wonder myself, and others I know have expressed this too, how many efficiency savings can we actually absorb? And sometimes it very much feels like there are simple solutions being given to complex problems, which is incredibly frustrating. I think as speech and language therapists, we do know, but we can't easily evidence exactly what's needed. And again, I hope this tool is a part of the answer towards that. Some of you may have a good understanding of what job planning is already, but it may be a new concept for some of you. So I'm just going to really recap quickly what job planning actually is. And it's a method of recording all activity that's undertaken by each individual member of staff. So that includes direct and indirect clinical care. So direct care might be the face-to-face work. Indirect clinical care might be a meeting about someone where they're not present. So a child in a school, you might be meeting with the SENCO, the parent. So that would be indirect clinical care. Or you might have a family meeting on the stroke unit. That would be indirect clinical care. So it's contacts that are recorded on whatever system you use, such as Rio, Oasis, PAS, System 1, but you might have something different. But it also captures the contacts that are not captured via those systems. So if you're a speech and language therapist in a school, you might have a conversation with a teacher about a child that's not on the caseload, where they just ask for some general advice. If you're on a ward round on the intensive care unit, you might have a conversation with the other members of that team about a patient that isn't yet or isn't ever going to be on the speech and language therapy caseload. And those are the kind of direct and indirect contacts that are not captured on Rio, etc. It includes all supporting professional activities. So that's everything from audit to research to journal clubs, everything else that we need to do as qualified and experienced speech and language therapists to maintain our professional registration. It also includes additional NHS responsibilities such as trade union rep and external duties such as delivering lectures at a local HEI where the money for that comes to the speech and language therapy department. There are a range of both strategic and operational benefits to engaging in job planning, which are laid out here. Only one is solely strategic, and that's the ability to model service capacity, which I'll explain a little more about later. And the others are both strategic and operational, so they can be very useful in the day-to-day running of the service, as well as in making the case for any changes that are needed. I'll leave that on the screen so that you can take a look at that there. I will be talking in more detail about what constitutes a quality contact in order to enable us to meet our requirements of our HCPC registration in a moment. So I've developed the SLTE job planning tool and I'm sharing it cost-free to enable ease of access and to reduce barriers for people. It strikes me as an NHS speech and language therapist that it's really essential that we share these things with one another, because when we pay one another for them, it just really does to me seem like we put barriers in place. In order to keep it intact, there is copyright in place on it. Which doesn't stop you using it, but it stops anybody making any changes. It calculates each individual SLT in your service. It enables you to calculate their capacity, and then you can utilise that information to calculate your whole service capacity. So if you're an individual SLT, you can take a look at what you look like on it, and you can discuss that with your manager, and you can see whether you're actually working to that or whether you're doing more or less than that. If you're a manager, it's a great tool to be able to calculate your whole service capacity, and it's all based on this concept of quality contacts, because I believe that we have to keep quality at the heart of what we're doing. A quality contact needs to include every aspect of the contact, and this is so that we can recognise all of the important components that are part and parcel of completing a piece of quality work. So this obviously includes the face-to-face work that we're doing with that adult or child that we're working with, either to assess them and or to provide therapy. It also needs to include time for writing up all of the notes. Now that might be one set of notes, but if you're working in a school, you might need to leave a note for a teacher. If you're working on a ward, you might need to write medical notes, and you may have separate speech and language therapy notes. So it's about making sure all of the notes are completed. There may be reports that are needed. Some contacts won't require a report, some will require more than one report. So those reports need to be included in the time that's allocated to provide a quality contact. There might be telephone calls that are needed. That might be calls to the family if you're working on a ward. It might be calls to a care home if you've seen a patient. It might be calls to the school if you've seen a child in clinic. There can be all sorts of telephone calls that are needed, and there needs to be time to do all of that. There also needs to be time for any other liaison, either with the patient themselves or with their family and with the MDT. That might be emails, it might be letters, but there needs to be time for all of that to happen. So the e-job planning tool is predicated on those quality contacts, allowing time to do all aspects of the work that's needed. And the calculations for the contacts are devised in a way that looks at a standard 7.5 hour day and then extrapolates that to the hours available. So this way any working pattern is accommodated. So we don't need to worry if someone's doing a short day, for example 5-hour days, or somebody's doing long days, for example 9-hour days. Those are both automatically accommodated because the tool uses the actual hours available. So the contacts are calculated for the year ahead, taking into account the predicted hours available for direct clinical care. Now, autonomy is so important in our professional lives. The way that a speech and language therapist who works on ASU will be quite different to one who works on general acute. The way that an SLT in special schools works will be different from one in community clinic. Now, because the tool calculates predicted contacts across the year, it allows each individual SLT autonomy to manage their day and their diary in the way that works best for them and the caseloads with whom they're working. Clinical service management time is allocated by band. I don't have time to go through that in detail today, but it's all included in the manual that's also available free of charge with the job planning tool. The tool itself is actually a spreadsheet with 2 tabs. The first tab is the job plan and the second tab is called My Typical Week. In the job plan, this follows the format of job plans as laid out by NHS Improvement, which was the body that first put them out for AHPs. And you complete it by working through each element systematically. You start at the top and work down, and there's information in the manual about every element to explain it. It's quite straightforward to use, so it depends whether you're somebody who likes to play with things or whether you like a manual, but both options are available. Some elements are pre-populated, some fill automatically and others need additional information, but all calculations are done automatically once you've put your information in. And then when you click on My Typical Week, you look at what work is done in hours on each day of the week. You put the information in across the week, and then it'll tell you whether the hours match the total hours provided on the first tab. And when you've done all of that, it will give you all of the information. So the information it gives you for each member of staff is how many hours are available for direct clinical contact, how many hours are available for supporting professional activities, things like CPD, audit, etc. And then within the direct clinical contact, it will give you the total number of contacts per year, and it will give you the number of contacts per year for each area of the service. And you're looking prospectively at the year ahead. So you're looking at what will be achieved in the 12 months from the point at which the job planning tool is used. And that gives you an ability to predict what that member of staff and then several members of staff, when they're added together, what can be achieved. A full evaluation was done of the pilot. So I did a pilot with support from RCSLT in 2023. The evaluation was really positive. It's being prepared for publication and will help us to provide an evidence base for the use of the tool. So the data outputs that are available for the job planning from the job planning tool are each individual staff member's predicted annual contacts from both the various areas of service delivery and overall, which enables you, when you add them together, to look at whole service capacity by looking at the totals. And you could look at capacity in specific areas of the service. So across adults and children's, you could look at any particular area of service and look at each individual that works in that area and then add those together. Demonstrating service capacity can be really challenging, and from the data that we've got in Wolverhampton, we're able to recognise where we're working beyond capacity, and I present this at my performance slides each month, and it demonstrates how far above beyond capacity we're working and enables us to make the case to change that. If you want to access the eJob planning tool, it's got a dedicated website and the link is there. You have free access to the full training package and free access to both the job planning tool and manual. At the moment it covers adults and children's, acute and community. In development we have the LD mental health section, which if I hadn't been ill would have been out by now, and the regional children's hospital section, which again, had I not been ill, would have been out by now. But as soon as I am well and able to complete them, they will also be on the website. Thank you all for listening, and I'll be able to answer any questions by you giving them to the people running this session, and I will be able to email in reply. Thank you very much.
Well, a big thank you to Charlotte for providing that really detailed presentation. And thank you also to everybody who has put a question in the chat for Charlotte. We'll make sure she gets those after the conference. Okay, so next up, I'm delighted to introduce two speakers for this final session. So we have Gemma West, who's the Early Years Lead, and Caroline Pethick, School Age Lead from Berkshire NHS Healthcare Foundation Trust. So over to you, Gemma and Caroline.
Thank you so much, and thank you so much for having us this morning. So I'm Gemma, and this is my colleague Caroline. Right. Before we start, we just wanted you to consider a few questions. Have you ever been part of a speech and language therapy team that has waiting lists to access the service? Have you ever done a deep sigh at the length of time an individual's waited to access your service? And have you ever seen a new referral and thought, oh my goodness, if only I'd been able to act sooner? So today we're going to tell you a little bit about our speech and language therapy inquiries line, which has made us feel better and helped us stop asking ourselves a lot of those questions.
So to give you a bit of a background about where we've come from, in 2022, in Berkshire Healthcare Early Years Speech and Language Therapy, we found ourselves in a very familiar situation to a lot of the speech therapists across the country at the moment. We had 1,500 children waiting who were referred to us, and that's 1,500 pieces of information about children with identified need that we needed to go through to prioritise and make sure that they got the help and support that they needed. All of these children were waiting well in excess of 18 weeks. And the impact of this was that at initial assessment with these children, we experienced really high anxiety from parents which added to the emotional load of each assessment on the therapist as well. Therapists often felt a little bit trepidatious, I guess, about initial assessments, and there was a decline in staff feedback on enjoying the role that they were in. The anxiety also added to the time each assessment took, because parents wanted to have kind of a good old moan maybe about the time they had waited, and also they weren't as activated from that moment. It led to delayed interventions. There was a long wait, and these long waits are very long when a child is 2. And we were all very aware that early intervention has much better outcomes for our young people. And we were not meeting that at that time. We also really observed learnt dependence. Having waited, parents were quite unwilling to be signposted to ordinarily available resources and advice. And they were inclined to have the mindset of only a professional could help my child. We'd really lost the trust from the parents at that very early stage.
So we set out to redesign our service, and we decided that going forward, we would have a service that was based on these 5 key aims or principles. And we wanted something that would be easy, so no lengthy referral forms or complicated systems to navigate. We wanted something that would be equitable, something that the majority of Berkshire population could engage in. We wanted something early that would address needs as soon as they arose. And we wanted people to access expert, professional clinical support when they really needed it. And one of the real fundamentals of what we realised that we believed in was that it does take a village to raise a child, that the child's ecosystem matters and impacts how, who and when an expert needs to get involved. Post-COVID, our previous systems of requests for help could be described at best as a little bit haphazard. We didn't just have 1 wait, but we had 2 waits. To the left of the green box, you can see that we had a wait for triage. We accepted requests for help in any which way that they might arrive. This was our initial attempt at doing something post-COVID to make systems easy and equitable, but the reality was that it was slightly crazy. The quality of information also varied hugely. Some referrals having lots of information, and some referrals saying things like, I just need speech therapy. We'd started to review these requests because of this variance in quality in an attempt at gaining clarity, but this resulted in telephone tag, or in worst cases, letter tag with referrers. Once we'd made contact, a decision was made as to whether to accept the request for help, which then led to a wait for assessment. The whole process was drawn out and inefficient.
At the same time we were looking at these things and all these inefficiencies, the whole of the SIPIT team were invested in care aims training from Kate Malcolmus, and then subsequent getting to the heart of the matter training. We did these to make sure that we were making the most of all the resources that we had and really prioritising the well-being of the child. We also did this to make sure that we were getting the most information from the conversations we were having from requesters. The key take-home messages were that conversations at the beginning of care could be really impactful. Conversations would focus on the desired outcome, so what's the referrer's best hope for the child, rather than desired input, I want speech therapy for my child. We were able then to jointly formulate plans for therapy that could be created using all of the expertise in the child's ecosystem. So, for example, the parent's expertise on their child and our clinical expertise as speech and language therapists. We could combine these to create a tailored care plan for the child, and the knowledge would develop impactful child-centred therapy goals. We also developed our universal training and resources. We listened to the research that says that parents really trust information that comes with an NHS logo. And so we created webinars, online training accessible to all. And we developed online resources. We developed local knowledge of groups and events that could be used to support therapy goals. And we really worked hard with our partners outside of the NHS to make sure that parents had access to exactly what they needed.
So we came up with a plan to start an early years inquiries line. Essentially, this would be a phone line which anyone could call to get some expert help from a speech and language therapist. This phone call would listen to concerns, direct to the local offer, direct to advice and support, or universal and targeted webinars. It would act as an advice call for some people, and for others it would be a kind of a screening time. For some, it would form the base of a dynamic assessment, a speech and language therapy assessment, which would start with that initial conversation and end with a face-to-face session in nursery, clinic or home. A decision which we would have come to with the referrer as where's the best place to see this child. At the end of the call, callers would be equipped with advice, reassurance, ideas and strategies that they could start right now, and they'd have a plan. Where consent was given, we produce a written plan outlining how that whole ecosystem can support the child and how the speech therapy team are going to contribute to that.
So looking then at the implementation, how did we do this? Well, it took a lot of planning. We needed to manage the backlog of children that we had waiting, ensuring that all of them had what they needed. We needed to train staff in how to take these calls, look at the IT systems, create the SOPs. We needed to risk assess on how we were going to ensure that the right children still got our support, and assess how much money this would cost. We did a lot of maths. We worked out that this was essentially going to be cost neutral, except for buying a few headsets so that therapists could be comfortable on the calls. And we had to make a plan to tell the community and stakeholders about the service change so that everyone knew what was going on. This is just an example of our communication plan. So this was an insert that we developed, and we asked for this to be added to every single health visitor red book that was distributed to every new child with every family with a new child. So that the families could have access to the help they needed exactly when they needed it, right in their red book.
So what did we learn? We learned the brilliance of timely conversation. As speech and language therapists, we know that conversation is so important, but this has taken our understanding of that to a completely new level. We gained increased parental engagement. Because most calls involve parents, we seem to have a real move from parents expecting the expert to do something magical in clinic with their child, to parents ready and willing to get involved to play their crucial role in therapy delivery. We gain no waiting times for response to first contact. If you feel concerned on a Monday, you can call on a Tuesday. The day you call or request help, you get some help and advice, and the journey begins. We learn a lot about waiting well. We know that this is a controversial phrase, but post-call, children are waiting around 12 weeks for completion of their first dynamic assessment, much better than what they were receiving before. But while they're waiting, they have a plan, and callers have the opportunity to make a difference. Yeah, we learned that there are increased numbers accessing our universal and online training, so we needed to learn how to expand that to deal with the demand. We learned that reduced number of children were being transferred into the service. Many needs were being met in that robust conversation. Many concerns were being alleviated. Just as a little data example, of the 953 calls that we've taken so far in East Berkshire this year, 48% have gone on to have an initial assessment. That's 461 children. 13% have gone straight through to a demonstration with a speech and language therapy assistant, because the speech and language therapist on the call was able to say, oh, do you know what? I think we need to do this, this and this. And the parent maybe was not sure how to get that done. So we're sending one of our assistants in to do a demonstration of how that can happen. And that has been really, really welcomed. Some children would go straight on to one-to-one therapy with a speech and language therapist, because that conversation has enabled us to gather enough information to know what we need to do next. Most importantly to us, in the first 3 quarters of the year following the launch of the inquiries line, we had no DNAs to initial assessment. Now that's groundbreaking for us. And to us, that spoke of parental engagement because they've been engaged in this conversation. They're now invested in their child's therapy. We've noted increased staff satisfaction. Clinicians are reporting that they're enjoying their jobs. They're saying it's really good to make a difference and alleviate concerns straight away. We knew it, but expertise makes a difference, and we've learned how to use our expertise in a different way, which has been really building. We've learned the importance of robust data collection. Data informs how the service is developed and continues to help us refine this offer. We can see when people call, how long for, topics of concern, and that can inform how we develop the service further to meet the needs of the population. We've learned that technology makes a huge difference. We've moved from our safe clinic rooms to developing our skills in the digital world, and it's been significant. We know the risk of children waiting those 12 weeks now. Previously, information was held as words and risk was largely unknown, but now we know what's coming, and so we can prioritise accordingly.
So just some highlights from this transformation. We were nominated for an All-Star Award for Best Clinical Team of the Year for Berkshire Healthcare. This really raised our profile amongst the plethora of adult services that are in BHFT. And we're really proud to be exemplars of transformation to other teams. And it's very difficult not to be convinced by us that this is the solution to many waiting list issues. Really importantly, we've had really great feedback from families and service users. People have noticed things like, this is an amazing service. I have access to private healthcare, but I don't see that this would add anything over and above what I've received from you. People have called in a couple of times to gain advice, and somebody said, this is the second time I've called this phone line. I'm particularly grateful that I can call immediately after attending an audiology appointment with my son to ask questions and get some further advice. So that's a parent whose anxiety has been alleviated almost immediately and has been able to get some really relevant advice to their child immediately, helping their child's well-being going forward and developing their child's speech and language communication. Somebody said what you've done in the early years has been transformative. The confidence of parents is through the roof as they know they can just pick up the phone, the nurseries too. They know what they can do. And that was from a local portage worker who we work very closely with. So it's great to have feedback like that from our partners in other organisations as well.
So quickly, what's next? At the time of submitting these slides, we were about to roll out an occupational therapy and physiotherapy enquiries line. Really proud to say that on the 4th of November, these did launch, drawing learning from the earlier speech and language therapy enquiries line. In turn, they're showing early signs of having had significant impact on the well-being of children, waiting lists, staff satisfaction and caller satisfaction. School-age speech and language therapy is going to launch on the 13th of January 2026. And by February, we expect that the front door to our integrated service in the east of Berkshire will be all via this easy, equitable and early phone call.
Thanks very much.
Thank you so much, Gemma and Caroline. That was fantastic to hear all about your experiences. And yes, I think just very best of luck with the future phases. It's been brilliant to hear the feedback that you've had so far. So unfortunately, I'm afraid we're going to have to skip over the questions today, but I've seen that there are lots of things coming in on the chat. So it would be amazing, Gemma and Caroline, if you could look at those and respond to them after the session finishes today. Lots of people are really keen to hear more about what you've learnt and how you've approached it. So that is amazing. So in the last 2 minutes of the session, I'm just going to sum up really and just provide a little bit of a summary of some of the things that might be useful for you if you're sitting there thinking and reflecting on the talks you've heard today and wondering where to go next. So in the next few slides, I'm going to be sharing a few resources from the RCSLT that might help you take your first steps in a kind of a service redesign or job planning journey. So first up, just a reminder that we have guidance on a range of topics that are themed according to different sections, and there's a link here on the screen where you can navigate straight to that section of the website to obtain that guidance. On the next screen, there's a link particularly about our Delivering Speech and Language Therapy Services guidance, which speaks to a lot of the themes and the topics that we've heard today, so that's one to look out for. On the next slide, I want to highlight that we've got resources on workforce. So we've got our staffing and resourcing guidance and workforce planning. And within this guidance, you'll find a lot of links that Charlotte mentioned in her presentation earlier. We've also got information on the website about care pathways and about healthcare improvement. So check those out if you're inspired by Gemma and Caroline's talk. And also we've got a wealth of resources on neonatal care for you to have a look at in your own time as well. So thank you very much to our wonderful speakers today. I think we've heard a lot today, a lot to reflect on, and it's been brilliant to hear these innovative approaches showcased at the conference. All that's left to do is to thank you all for joining our session today, and we thank you very much for your attendance and your participation, and enjoy the rest of the conference. Thank you.